All right, everybody, we're going to go ahead and get started. There's a couple more people that are going to be joining here, but in the interest of time, we'll get started. We have a didactic presentation from Dr. Baltiera, and then a case discussion from Laura Lander. So I'll turn it over to Dr. Baltiera. He's going to lead us off. And please use the chat to introduce yourself if you haven't already done so. And if you have any questions, feel free to go ahead and pop those in the chat as well. I'll turn it over to you, Dr. Baltiera.
All right, I'll have to remember to turn on my mic. So welcome everybody. I'm David Baltiera. I'm a family physician. I run an MCOT program at Harper's Ferry. And so I'm going to kind of run through, there's a lot of slides. I use slides as a reference for you later. So there's more slides than we'll possibly be able to go through, but hopefully it'll go well. And if there are any questions, just pause or stop me. So we're going to talk about maternal comprehensive opiate addiction treatment model, an integrated model of care that we do in family medicine. I don't have any disclosures. So our objective is really to describe the scope of substance use disorder in pregnant patients and families in West Virginia, describe a model that we've used successfully for the last 5 years for pregnant patients and families with substance use disorder, and hopefully make everybody more comfortable with using buprenorphine and supporting families that particularly are suffering from opiate use disorder, although we're seeing much broader polypharmacy and multiple addictions as well. So more of a rhetorical question just for people to think about. It'd be great if we could kind of see, but do any of you have experience providing medication for pregnant women and families in opiate use disorder? And I'm sure we've got the full gamut. No, some have observed it. I know Morgantown has been doing it with pregnant women longer than we have. And I know Marshall's been doing it for quite some time as well. So we'll point out some of the differences of our model and how we think it works well by integrating care completely. So everybody's pretty familiar with this start of the problem with opiates and addiction, although addiction's been going on much, much longer. But in the 90s, there was an increase in the rise of prescription opiates. In 2010, a marked increase in deaths from heroin. And then in 2013, we started seeing an increase in synthetic opiates, which at the time they were talking about fentanyl, but also oxycodone and other opioids as well. Now in 2022, we all know that that's increased much, much more significantly. And so this is the overdose rates involving opioids in the United States. And as you can see, there was clearly an increase in heroin mid 2015, and then it started coming down. And then we started seeing a huge jump in other synthetic opioids, particularly fentanyl, is what we see. And then the other semi-synthetics and other opioids are there. So where does West Virginia fall in opioid related deaths? Well, unfortunately, we lead the nation. Our overall overdose rate is in the 80 per 100,000 range. Most of that, 90%, is related to opioids. So in 1999, West Virginia had 1.8 deaths per 100,000 opioid related overdoses. In 2020, that was 70 per 100,000. And the United States was running at about 21 or so. So we are over 3.5 times the rate of the United States, and have increased by almost 40 times almost from 1990 in deaths. So again, deaths are continuing to increase. 107 drug overdose deaths in 2021 in the United States, which is an increase of 15% from 2020. So things continue to not look well. West Virginia, here we are in the middle of the big opioid crisis. New England, Mid-Atlantic, Midwest, and then in Florida. And here we are, West Virginia, our total overdose rate. The top 10 states were leading at 81.4 per 100,000 deaths. The United States is at 28.3. And what we've been seeing is an increase in total deaths, particularly synthetic opioids. We're seeing, interestingly, a lot more stimulants of overdoses. People used to die of stimulants, but not as much of overdose. Now we're seeing that in a lot of polypharmacy as well. So looking particularly at intrauterine substance exposure and neonatal abstinence syndrome in West Virginia, our pediatric colleagues have done a great study they published in 2018 where they actually matched up to see the validity of data that they were getting through state records. They actually measured, and what they found was in 2016 to 2017, over a 15-month period, infants that were exposed to substances in utero in West Virginia was 14%, and of total NAS was about 5% in the state. Here's a map looking at the areas with the most exposure. So region 1 has intrauterine exposure of about 18.5% and NAS rates in over 8%. Region 4, which is where West Virginia University is at 13.5% for intrauterine exposure and NAS at 5.7, almost 6%. Region 2, which is where we are, where I practice, it's 15% and NAS is 4.21. So that's some statewide data. And obviously there are some patients from in and out of state included in that. This is a little bit of a complicated table, but if you look across just picking a region, 18% intrauterine exposure, NAS of 8% in region 1. Of the newborns that were exposed, 45% had NAS, so about almost half of them. But it's interesting though, how different that is in terms of infants that are exposed to substances. I mean, it's as low as 1.7 or 17% of the infants exposed developed NAS and as high as 45%. So question of whether that's diagnosing, labeling appropriately, or different models of treatment. So moving on to why should we treat pregnant patients with substance disorder and their families? Well, obviously, there's been a huge need. There's a huge community need. If we don't address the entire family, we've seen multi-generational. Currently, my oldest patient in substance use disorder is 83. My youngest one has been 16 that I've treated, and we've had younger because we're not permitted to treat below 16 without special permission with Suboxone. But definitely, so that's, definitely multi-generational. We've seen newborns, parents, grandparents, and even great-grandparents. In family medicine and as a land-grant university and everybody who works in healthcare, we definitely target vulnerable and disenfranchised populations. In family medicine, we truly believe in the integrated biopsychosocial model of care, and this really brings all that together for us. It also is a unique niche that I think clinicians that work with entire families can really fill. We're privileged to be able to take care of a pregnant mom, her parents, the infant, and follow them throughout their life. Currently, we have patients that are on their second and third baby that are with us, and we've taken care of some of the families for over 5 years and continue to see the children in our practice. So for family medicine, it's also an important practice for training to have access to maternity care and teaching our residents the continuity of care. It provides a great professional satisfaction. I grew up in the era where we basically, for alcohol, we said, go to AA. For substance use disorder, we said, here's a bucket and suffer through the withdrawals. And there really wasn't much else besides abstinence. I think with the era of medication-assisted treatment, we've come a long way. Also, many of our patients suffer from primary and secondary comorbidities and mental health issues. It's also a great way to advocate for our patients and support for intact families. The foster care system is clearly overrun, and keeping families together makes a huge difference if possible in a safe environment for children. So this is our program, Maternal Comprehensive Opioid Addiction Treatment Program. It's the integration of substance use disorder and maternity care at multiple sites of care, but anchored really in our family medicine practice. We provide prenatal, natal, postpartum, newborn, and family care. all by the same treatment team. Now, that may not always be the same individuals, but it is across multiple sites with communication. Actually, having an electronic health record has helped facilitate that, particularly through immediate communication. Downside for us is I spend all morning getting secure chats. I'm sure lots of you get those. I get them all day long for intakes on new patients and crises that happen, but the patients get access to us. Not quite always in immediate real time, but as much as we can. This all started when I went to a conference back 2013 or so, at the Perinatal Partnership, and where the perinatologists had started treating pregnant women with buprenorphine. And they were doing it for 6 weeks throughout the pregnancy, and then 6 weeks postpartum. I said, sure, I can handle that. We decided to extend our treatment out to 2 years because really, who was going to take care of the patient after that? There really is nobody else. And we've extended that treatment indefinitely. Like I said, we've been running the program for 5 years, and I still have patients in our groups at over 5 years successfully treated. Not everybody's been a success, but many have. It's really important to have a high structured, accountable program, and it needs to be financially sustainable. Fortunately, in West Virginia, with our Medicaid expansion and coverage through Medicaid of substance use disorder treatment through buprenorphine, it's financially viable as a program. So we don't rely on grants to continue the programs. This is really based on our colleagues at WVU who developed the COPE model. And if you want to look at kind of cool videos, they're press articles, all that. They've really mentored us through that. So this is that. So this is our advertising brochure that we get out to patients and communities, and it really includes integration of substance use disorder, prenatal care and delivery, weekly medication management group, weekly group therapy, and monthly individual therapy. And those are the key components of Morgantown's program as well. And patients really like having it all integrated in one place. And obviously this has changed through the pandemic, and much of it has shifted to video. And honestly, I've been taking care of some patients that I've never met in person, which is really a challenge and interesting fact. We also have a program about community interventions for recovery through community linkages. It really is a program of wraparound care for the entire family. So if a 14-year-old comes in with grandma for a physical and her life has been affected by mother's substance use, or grandma's struggling with dealing with their daughter or son who has substance use, this team will intervene and help provide them support through therapy, referral to case management, transportation issues, medication-assisted treatment if needed, vocational rehab. It's really a true multidisciplinary approach. So these are the components of our program. And as you see, our community outreach is based with case managers. We have phone contacts. We have a medical team that does the opioid addiction treatment program and the management of pregnant patients. And we have multiple sites that are able to provide that treatment. The other element that we have, and that I think is really important, is having our family medicine residents participate in this. And part of it is partly big stigma reduction. We've noticed that the more our patients are cared in our office, the less stigma they suffer through, and the more humane care that they receive. And hopefully that carries out as our doctors go out into practice. We also see it in our office staff, and we've lost a little bit of that with the pandemic, since our patients are only on video. Not everybody is exposed to them coming every week into the office. And so that is something that we've lost during that time. As I said, it involves a case manager, behavioral therapist, medical assistant, physician, or other way for provider, our front desk staff, and scheduling, our residents, recovery coaches and peer coaches that are in our community, and our maternal child health fellows are also involved in it. So our treatment centers around medication-assisted treatment with buprenorphine. We provide integrated medication managed group visits weekly for 30 minutes and 60-minute behavioral therapy group visits. There's case management, true honesty and accountability, and an integration of the maternity care so that we can get patients in. During the pandemic, that's changed a little bit. The maternity care has become a little more fragmented, but we continue to emphasize coordination of care. Unlike other programs, we actually keep our patients in weekly for 1 year until they've obtained full recovery during that time. The reason is we don't require additional peer support meetings, and we feel that our patients need that time, particularly during pregnancy. Once they reach 12 to 18 months of recovery, they're able to move on to every 2 week and then monthly at 15 to 18 months. And then now we have patients in maintenance, which are seen bi-monthly or every other month for 3 years as well. All right, so just a few issues, and I'll talk very briefly about the actual medical management of patients, but we've always used Suboxone, and occasionally we have used buprenorphine, but West Virginia Medicaid on formulary only permits Suboxone, and we've had no issues really with pregnant patients doing that. And locally, our pharmacy and everybody else is accepting that. We encourage peer support, faith-based and abstinence self-help groups, but we don't require them. Relapse is a true part of this process. Diversion is always an issue that we continue to struggle with. Most of the patients now, and I think many people that are doing buprenorphine programs will agree, patients come in already on treatment and started themselves on Suboxone many times. So that just says that there's a supply of buprenorphine in the community. And then, obviously every patient gets prescribed naloxone, and we deal with their social issues and their history of trauma and addiction. So this is kind of what it looks like. It's all based at Harpers Ferry Family Medicine. And then our other partners are the local hospital, labor and delivery, newborn care, labor, and then our programs that kind of help support the core of the program. So intake comes from many areas, from self-referral many times, OB providers and family medicine providers. Our hospital team will call us to consult on inpatient, both in the labor and delivery unit, on the medical unit. Patients may come in with different other medical issues. The emergency departments provides bridging, and we coordinate with them. Rarely does it come from Child Protective Services, occasionally through Help for West Virginia, and then through our own internal services. Patients get a medical psychological evaluation with in-depth substance use history. Many have a history of incarceration and involvement in Child Protective Services, and a long family history of substance use and often violence and trauma. We really aim to find out what their support systems are, and what other substances are available, are being used within the house. And unless we treat the entire family, it's really hard to just treat a pregnant woman. So that's why our program's really expanded to families. We even, one is an uncle that was living with one of our pregnant patients. He's now 5 years into recovery, doing well. And I just saw him this past week. Our idea was to provide the initial OB care at the same time and prenatal care. Again, with COVID, that's changed, and so we've split up that model. Best guide for treatment and guidelines is this here, and there's a link here. And basically, the induction and medical treatment is the same for patients. We rarely induce patients anymore. They actually induce them into their buprenorphine treatment, not labor. Because they all come in already on treatment. The challenges that we have faced is patients that are on fentanyl, oftentimes transitioning them to buprenorphine can be a little more difficult. Also, patients that are on methadone that want to come off of that onto buprenorphine is also a challenge and may have to be admitted inpatient. So at labor delivery, we provide antenatal management. So patients come in and they admit to a substance use disorder, we will start treating them then and there. We really are focused on family-centered birthing, respectful patient-centered decisions, and try to avoid kind of stigmatizing and searching patients and doing things like that that would make them not want to participate in their treatment. Medication issues in labor, intrathecal and epidural morphine works well Epidural and spinal work well, occasionally with good variability. Rarely do our patients need additional pain medication, even for C-sections, besides ibuprofen, their buprenorphine and ketorolac, which is Toradol. Oftentimes, if they do need additional medication, we'll give them short-acting buprenorphine every 4 to 6 hours. Challenges that's not paid for by their insurance, but patients are willing to pay for it and often don't need it for any more than 3 to 5 days, which is pretty amazing. These are patients that many would perceive as needing additional pain medications have not. Newborns usually at our hospital stay for 3 to 5 days. We don't have a NICU, and very few of them end up in the NICU. We encourage breastfeeding. Mother is really the first line of treatment for the children's NAS. And we will use morphine if needed, although I'll show you some data how that's gone down significantly. Complicating the picture, though, is other substances that may be in the community, including nicotine, benzodiazepines, alcohol, methamphetamines, MDMA, gabapentin. We're seeing other drugs like boot, which is pentalone and methylone and ethylone. And then we're also seeing xylazine in the community, which is a horse tranquilizer, and have no idea how that will affect our newborns, honestly. I do know gabapentin and nicotine have created some issues with our newborns. So this is our data that, Dr. Elder is no longer a PGY2. She is now one of our maternal child health fellows, but the date she pulled from 2016 to 2020. And at Jefferson, we deliver about 200 babies. So 2016, we had 12, and in 2020, we had 17 babies with exposure to opioids. The number with NAS actually went down because of probably the way we treated mom as more being part of the medication. And the number getting morphine replacement therapy went significantly down. So only one infant got morphine replacement therapy, although our numbers of infants exposed went up. Our median length of stay went from 13 days down to 3 days during that time. Fortunately, that has not resulted in readmissions or harm to children. So it really is a change in our approach on how we treat them. All right, so I'm going to go through a little bit of these because these are some of the advantages for residents. It really is a stigma reduction and gets more physicians comfortable with doing this. And then just to mention, we really have needed to expand our family programs, and those have been essential to keep families intact and help them function. So what have we learned? We learned that it's important to really scale this up. You don't have to do it perfectly, you have to do it well, and you grow as you do this, and you take on more and more challenging cases. But caring for families in this model really supports stronger families in the community, and really essentially, this is treatment that needs to be in the community, not in an inpatient setting. Most of our patients can be treated in ambulatory settings. So self-help may or may not be necessary, but close connections and accountability are essential. So kind of wrapping up, this gives you kind of our timeline, kind of our personal history. 2004 was the first baby at NAS that we took care of at family medicine at JMC. And 2007 was the cord study that showed 20% of newborns cords in West Virginia had drugs or alcohol exposure, 5% had alcohol. And then 2009 is when there was a good presentation as this was all growing. And then as we've increased, we started our program in 2017. And so we're in our 5th year, but still some of the same patients. Patients tell us that we really need to treat them like humans, don't judge them. Suboxone really does help people stay in recovery. And the biggest thing they struggle with is shame. And, some of the quotes that are pretty, they've been told that some people would let you die if you're on Suboxone. And they're all varied and different. So, all right. I've got resources on the PowerPoint that people can connect to, and I'll leave a couple minutes open for questions or discussion. Sorry, it was so kind of flying through all those slides.
Thanks, Dr. Baltier. That was great. Yes, does anybody have any questions? Go ahead and unmute or put them in the chat.
Thanks, David. This is Laura. So I'm just curious, since you were not trained as an addiction prescriber and you've made the transition into this work, what are your thoughts about how do we I don't know what the right word is, entice or interest other OB providers to doing some of this work and support them to do that, just kind of as you've experienced through your journey?
Yeah, I think it requires people to be open to taking care of their community. And one of the things as family doctors, it's easy for us is we shift gears and morph into whatever's needed. So, we have family docs that do HIV, now they're doing hepatitis C, and it's because there's nobody else to do it. And so I think it's really training from the med school level on that we have a community responsibility to really take care of that. And that's what I was impressed, really, like I said, back in 2007, 2009, perinatologist from Marshall said, I just found this Suboxone stuff and I think it's great and we're going to start doing it because he needed it, and that's, I think, really, and it isn't that hard. Kind of our goal has been to, I would love to be out of business doing this. And if somebody else would want to do it, I have other things I can do, although this is very rewarding, but it's getting our maternity colleagues to refer patients to these programs. It's not even that I need them to do it. Sometimes I'll get a call and say, so-and-so, we got a patient just delivered yesterday and they're on Suboxone and they've been seen the whole time and they've been buying Suboxone off the street. And I'm like, we can intervene beforehand. We can take care of this. This is actually, and Suboxone's the easiest part. That's actually prescribing the Suboxone. Patients come in and tell you how much they're on and you continue. It's really not that complicated anymore. There are complicated cases, but generally it's not. So I think it's that, Laura, is just partnering with our OB colleagues, getting them comfortable with it. We require all of our residents to do the waiver training, even if they'll never prescribe, just because they learn what it's about. And I think in West Virginia, everybody who does maternity care should do the waiver training, whether they prescribe or not is a second goal, but at least they should be aware of what it involves and what it is.
Thanks.
I have a question, Dr. Baltiera. You were mentioning that sometimes there being a barrier in getting specialty OBGYN services, like getting people to actually refer to MAT program. What are some things that you found that have helped to overcome that barrier?
Yeah, I think it's really connecting with them personally, working as colleagues. I think I also think many of our OB colleagues are really busy and patients don't get asked all the questions. And it's tough, they'll say, do you use drugs? And the patient says no, or are you, and it just kind of falls to the wayside because they're so busy. So I think having adequate time to target those patients is important. I also think, I have mixed feelings about universal drug screening, but I think it's actually less targeting and less stigmatizing and less biased if we screened everybody at the beginning and every time and when they came to labor and delivery, as opposed to, oh, you look like you may be using, or oh no, you're my neighbor, you can't be using. Well, guess what? None of those are true. So I think universal screening to decrease bias, and then just really working with our OB colleagues and let them know we're there for them. Sometimes they don't know we're available.
Any other questions from the group?
I'm just curious what changes you guys had to make during COVID time, if there were any changes at all, mainly with like the prenatal care piece, because I know like we had to make a lot of pivots.
Yeah, the prenatal care piece we struggled in just trying to get patients in, and people are getting less prenatal care. I think it's really a problem. And so they're falling through the cracks, and they think that getting their Suboxone is their prenatal care, and it's not. So we really do emphasize that. And I don't want to withhold their Suboxone for their prenatal care, but there have been a few cases where we've had to, because it really was essential. But like most everybody, within 3 weeks, we flipped a switch from never doing telemedicine to doing it all the time. It's opened up a lot more patients, saved them money. So I don't think there's any going back to the other way we did it. I think we still miss some of the in-person things. I would love in West Virginia, there is now technology that we could do distant prenatal care. There are monitors or blood pressure cuffs. We really should be targeting that for some of our populations that have transportation problems. Problem is, we also have poor internet access, so all those rely on those technologies. But ever since, where the buprenorphine guidelines have eased up, the video guidelines have eased up. I'm in a rural health center. We're not legally allowed to do video visits except under the pandemic emergency, so that could go away for us. There's now, many of our patients get free internet through a federal program that's available. So all those things have helped and made it possible that I think we're providing better care, more availability. From my side, maybe too much for my own personal wellness and balance, but for the patients, it's great.
All right, thanks, Dr. Baltier. We really appreciate the presentation. We will send the slides out, for all the resources that were in there. So thanks again. All right, we'll go ahead and transition to the case. Laura, did you want me to share it, or can you share it? Doesn't matter.
Yeah, can you share it?
Absolutely. Give me 1 second, and then you can take it from there.
Okay. And I apologize for any typos, because I don't think our thing has like I've gotten really dependent on like a machine to correct my spelling, but we will forge ahead here. So I wanted to present this case, and so this is a case that Kelly Lemon and a patient that Kelly and I worked with in our clinic recently. And it kind of highlights an issue I just wanted to raise around what we're seeing: more use of methamphetamines with generally people who use substances, including pregnant women. So methamphetamines has been an increasing problem for us that we're seeing, and I assume many other people are seeing this as well. So the general question for the group and Dr. Baltier, I'm curious about your thoughts. We'll get to this at the end, but generally, is it possible for regular methamphetamine use can cause what appear to be symptoms of severe preeclampsia, and would it be reasonable to try residential treatment and abstinence from stimulants first before recommending induction, which usually is recommended at 34 weeks. So we'll hold that question to the end, but sort of that frames where I'm going with this case. So this patient presented to intake in our outpatient setting in July of 22 with opioid use disorder and stimulant use disorder, methamphetamine type. And she got enrolled in our comprehensive opiate addiction treatment program. She was pretty honest about her use of both. She had been taking buprenorphine off the street, so the stimulant use was an issue. And it's funny, I did the intake, so I remember asking her, so does your partner use stimulants? And she's like, yeah, on and off. So we'll just keep that in the background. So she was a little bit guarded. This is an individual who actually had at one point 4 years of sobriety and had worked in a residential treatment setting as like a peer recovery support specialist. So she had tremendous shame and guilt about now finding her back in this place, really struggling with a different substance. Before, she had used opioids and benzodiazepines. And she said methamphetamines are totally different. She came to realize it was so much more difficult to discontinue use from methamphetamines. She initially reported being able to obtain about a week of sobriety, even 2 weeks of sobriety before she relapsed on methamphetamines. We were seeing her virtually. She was using IV. Had we been seeing her in person, I think we would have known very quickly that was not the case, because when she uses, she gets pretty bruised up on her arms. So this is just one of the things I think about when we are doing all of our clinics for COAT virtually, which I struggle with at times. And I feel like we would have caught her struggle earlier had we seen her in person. But eventually she really began to get more honest and say she was not really gathering any significant sober time. She was living with a partner who was using methamphetamines regularly. We did recommend detox, and she was able to, we really were recommending residential, but she was willing to do detox. So she went into detox at the Center for Hope and Healing for a week and came out. She did not maintain sobriety for very long after coming out. Again, living with someone who was actively using was a struggle. She then disclosed some housing issues, and so it became apparent, even if she had been sober, would Child Protective Services even allow her to bring a child back to the kind of setting she was living in? So we kind of got on the bandwagon of helping her apply for HUD housing and talking about, really needing to make a change. And then at 29 weeks, she was diagnosed by our OB providers with severe preeclampsia. And she was at this point using daily, and we were encouraging her to come back in for residential treatment. She had a job and she was able to somehow maintain the job, and she did not want to come back in for residential treatment. So we were just trying to kind of retain her in treatment from, in some ways, a harm reduction approach, continuing to prescribe buprenorphine. She was being honest about her use at this point, and then she was diagnosed with severe preeclampsia, admitted to the OB floor. Well, as you can imagine, our OB providers were not really well versed in how to handle someone in withdrawal from methamphetamines, and this young woman who has a very strong personality. She's like, when she's sober, she's amazing because she's like a fierce advocate. But when she is in withdrawal from methamphetamines, she is highly irritable and combative. So that is what they saw on the OB floor. And it was really, really difficult for her. It was difficult for staff. She got in multiple altercations with security, as did her boyfriend, who was eventually banned from the hospital. So this was not good treatment, in my opinion. And so one of the things it raised is, could she have been managed once sort of she was medically stabilized, could she have been managed better in a setting that's used to dealing with patients who are struggling with methamphetamine withdrawal? And would you have been able to retain her? So she was sort of in and out. So she left the hospital AMA and then came back, and there was this back and forth. And when she left, she would use. And so we were trying really to advocate for her to be in a setting where to treat her substance use disorder, because we did see some of her levels go down when she was inpatient and she was not using. You can scroll down a little bit. So just some of the lab results. So we did see like blood pressure go down, and some of her other labs go down. I think, Kelly, if you want to chime in about what her labs looked like over the time she was in kind of inpatient, and get all of those.
So the thing that really, I think, also was the complicating factor in this, because a lot of my colleagues, I think it was like, well, her blood pressure's up, it's a no-brainer. But you think of all of the mass effect that you have with methamphetamine on your body. She also was like a chronic hypertensive patient who, when she came into care for her new OB visit with me, was normotensive and not on meds. So we did not start meds because she was normotensive. But at that phase, she was also in the second trimester when your blood pressure physiologically dips. So she had a mild range pressure in the clinic with our electronic cuff. Her manual repeat was normotensive, and they just did a panel of labs to kind of cover their bases. They ended up seeing that the lab work, her liver enzymes were elevated, and that's why they called her and told her to go into the hospital. So it wasn't not even like a persistent elevation in blood pressures that sent her in. It was that her LFTs, like her AST and her ALT, had bumped in the peak of her use.
Right. And so we know that methamphetamines can produce that kind of lab result as well. So it was an interesting back and forth between the addictions team and the OB team, which was probably frustrating for both because we were really seeing it from the addiction lens and they were really seeing it from the preeclampsia lens. So in part, my question is, have other people seen kind of this presentation with patients who then get hospitalized and struggle with the medical care setting? And then any thoughts that people have about treatment? And then I'll tell you what happened. So we'll do the follow-up after.
So Laura, I think, and Kelly, that's a great case because I think we need to get better at methamphetamine treatment. It's different than our opioid patients. Really, I think we've gotten very comfortable with Suboxone and treating people. And I was almost not joking, but saying, wow, we just don't see patients coming, that are on heroin or fentanyl anymore that haven't been in treatment. We see a lot more people in treatment, but now we're starting to see this. And I don't know, I think it's really coordinating the teams together because I think putting this patient, so when I started practicing 30 years ago, we used to hospitalize people and just keep them in the hospital and that maintained their sobriety. Now, it wasn't forceful hospitalization, but if they're there and they're getting food and they're getting taken care of and they're being observed for their preeclampsia, that's a totally rational treatment approach for this patient because we know that methamphetamines lead to smaller babies, earlier deliveries, and other things. The other part that I'm concerned about is this patient was probably testing positive for methamphetamine, but the potential of other drugs now is so big, we don't even know what there is out there. And so I do think a residential plan for this patient would have been a good thing. And even do you do visits at, the residential facility for their OB care? I think that's what we need. We kind of need those facilities where you can do that. And in places that you can't, you keep them inpatient if they're willing to stay. But then it creates a lot of, turmoil in the system. And, I just had a patient this past weekend that was in for a hand abscess from cutting her hand and had been in recovery for over 5 years. And they threatened to search her daughter because she had history. And I'm like, that's a problem. And so, we still have a lot of stigma, a long way to go. And these patients aren't easy and they create some of that stigma too. And so it's a challenge, I think. But I do think it's having kind of, this is the high risk patient that we should be having case management conferences on, not just the preeclamptic or the repeat C-section or the triplets and stuff. It's how do you manage their whole social, that's as high risk as everything else. So.
It was interesting when what I witnessed when she would be inpatient, she would have when she first came in actively withdrawing, that was the only point where she was a little bit more irritable and she had a little bit of conflict with nursing staff. But by the end, all of the nurses loved her and have been asking me how she's doing because she would try to go outside. The big kerfuffle with security was she just wanted to go outside and smoke. and she would go outside and security just took a really firm stance on it. And the nurses were like, okay, well, she's not a prisoner. Like, we'll walk out with her. Like, so they were all very supportive. And by the end, they would like band together as like a front to like face security in her defense. So I also found that to be like really interesting, but a little bit uplifting that all the nurses were like, you don't mess with our girl by the end. So I really liked that.
Yeah, I'm just curious about other people's experience if you're in an OB setting, because this has made Kelly and I think about doing a case report because I suspect this happens with some regularity given the rates of methamphetamine use. And there's not, Kelly did sort of a search of the literature, there's not a lot of literature out there about if you just discontinue the methamphetamine use, do you see all those symptoms of severe preeclampsia resolve or not?
Right. And are they symptoms of severe preeclampsia, or are they side effects of the medication? Methamphetamine gives you hypertension.
Right.
Methamphetamine, you get dehydrated and you get liver enzymes going up. Is it truly preeclampsia, or is it something that looks like preeclampsia and it's just methamphetamine use?
Exactly.
I don't know. I think our colleagues on the West Coast probably have a better idea because they see this a lot more. But I think you're right. We're going to see it more and more.
Yeah. So I'd done a literature search to try to like back up, because we had a pretty strong like contingency of behavioral medicine team coming in and with this particular patient, trying to do like a multidisciplinary like case management group saying, hey, we really think it's this. My OB colleagues were being very firm on, there was a couple that agreed, but overall pretty strong stance that no, this is severe preeclampsia. I was over on the behavioral medicine side going like, I don't think so. So I'd done a lit search to try to pull some articles to back it up. And it was interesting. Everything in the literature just said methamphetamines cause severe preeclampsia. And that was the be all end all. And so it's just kind of begs the question, like, and it makes sense in the treatment guidelines. If you have severe preeclampsia, regardless of your gestational age, if you're having like bumps in your liver enzymes and you have severe range pressures, like you deliver, that's what you do. That's recommended. So everything in the literature is, oh yeah, they get severe preeclampsia and you have to deliver them. But literally no one had anything published on what happens if you stabilize them and monitor, like, and their liver enzymes go down. Like, what if we're not actually doing good follow-up? No one had follow-up after delivery because they deliver those patients and they start to see an improve. Yeah, they have been inpatient, their liver enzymes drop, and they say, oh, it's because we delivered the baby. So there also wasn't good follow-up data either.
And I don't know if you're part of the Association of Addiction Medicine Women's Addiction Group, the WAG. Mm-hmm. They have and that may be a place for you, and I can send you that. It's a bunch of maternal fetal medicine people that do addiction. So those are the people. So the people that published on that are in that group. And so they're the ones, but they're very forward thinking and actually, kind of, and do you do some harm reduction? Do you have this patient smoke is the least, smoking's horrible in pregnancy, but leaving to smoke and not getting treatment may be worse. And do we, I'm all for stopping smoking in hospitals and all that, but are we doing harm? I don't know. It really is. We should be asking these questions because I would guess so many of our patients leave because of smoking. It is not an uncommon, battle. So,
Dr. Baltier, can you send me that link to that group? I'll send it out to the entire group.
Yeah, it's not a public group. You have to ask permission to join it. So that's the only reason. It's through the American Society of Addiction Medicine. And they kind of, it's not, so it's not totally a public group. So it's somebody who does obstetrics and that. Yeah, that's the only reason. Yeah. But I can send their webpage. How's that? And then people that are interested can look up. So I'll get that for you.
Perfect.
I think, Laura, you may be on there, but they're just brilliant people that do great stuff.
Any other thoughts or questions about the case or Dr. Baltier's presentation?
I'll say, Laura, that so many things resonated with me in that case. I didn't really know what to seize upon to offer a comment. But I think what is the highest priority in my mind is that in order to even create opportunities for things like that to happen, we definitely need to expand women's residential treatment in West Virginia, specifically for the PPW population. A huge barrier in our area is that we have one program, Project Hope, which is affiliated with our department, that allows moms to take their baby back, you know, to their apartment in residential treatment after having the baby. Everywhere else, once you're postpartum, you have to go through a 28-day program first, and you can't have your baby during that whole 28 days. It's a huge barrier. And so with, you know, 14 beds serving I estimate about 7-county area, for the most part, that's just not enough. So expansion of those kinds of services and family-based services is so important.
Yeah, and the reason, so we had hoped that she would stay in residential following detox. She didn't want to do that. She thought she could sort of sustain sobriety out of the residential treatment setting. She wasn't able to, and then she did agree to go back in, but then she was on a wait list. And then she got diagnosed with severe preeclampsia and went into the hospital. So she was just waiting. The good news is she did deliver a healthy baby who needed a little bit of NICU support initially at 34 weeks. And she was able to spend some initial days with the baby in the hospital until CPS did an about face and force her to leave, which I don't understand because it was a supervised setting. But then she did go into residential treatment. So she is in residential treatment now, and hopefully will come out, and she wants to fight for custody of her baby.
Any other questions or comments?
So just a quick comment. I know, you know, many places have neonatal transport teams. They have, you know, kind of maternity transport teams. What we really need in our state is a maternity treatment team that helps coordinate beds. Because I'll even say, you know, it's great, you know, kind of in Huntington, you guys have that. But here we have Mountaineer Recovery Center has beds, but I don't really know what they do. And so I need to walk over there and just kind of see, but you know, you almost would need, where is there a bed for this patient that they can get the care they need throughout the state? And so that would be kind of a great, you know, vision through the West Virginia Perinatal Partnership, kind of a statewide coordination for that. So that
and then coordinating transportation, because she didn't really
Right.
Transportation. Yeah, that's a great idea.
All right, if there are any other comments, we can start to wrap up. Thank you, Laura and Kelly, for the great case and great discussion, everybody. Just as a reminder, our last session for the year is going to be December 12th. The good news is that we are going to continue the project. It'll take a break in January and we'll relaunch in February. More information will come out on that as far as making sure to extend your Zoom registration for the sessions and things like that. So be on the lookout for that probably after the Thanksgiving holiday. We'll send out those communications. So that's all good news. So if we really encourage you to present a case for that last session. We'd like to really finish out the year strong. So if you have any questions or anything you'd like to discuss, please go ahead and pop that in the electronic form and we'll make sure it's discussed.
Yeah, we're asking for people to make suggestions about topics, right? Yeah.
Correct. Yep. So we'll do more of a formal process, like I said, after Thanksgiving here of requesting topics. And then we'll also do that at the December 12th session as well. So you have a couple of opportunities to do that. But obviously, if something pops in your head between now and the next session, send us an email so we make sure we can document it and get it marked down. All right, everybody, have a great rest of your week, and we'll see you here in a month.
Thanks, everyone.
Bye, everyone. Thank you.